This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub Podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Elara. Today we're looking at a fascinating new study from the journal Neurology India, published in 2026. The paper is titled Saraj Retractor, a novel retractor system for deep-seated intracranial surgeries, and its comparative analysis with conventional retractor system.
This is a timely topic, Elara. In recent years, we've seen microneurosurgery and minimally invasive neurosurgery become the standard for managing complex intracranial pathology. Whether we are talking about intraventricular tumors, intracranial hematomas, or posterior fossa tumors, the goal is always maximum exposure with minimal disruption to the surrounding neuroarchitecture.
Exactly, Dr. Aris. But the authors of this paper point out a significant bottleneck in our current workflow. They note that for deep-seated lesions, we require bidirectional retraction of the normal overlying brain tissue to achieve better surgical access. However, when you look at the history of our field, conventional retractor systems have been in use for many decades without any significant modification or innovation.
It's true. We've been using the same basic metallic spatulas and arm systems for a long time. While they work, they often present ergonomic challenges or can inadvertently obstruct our line of sight. This study introduces the Saraj Retractor, which they describe as a novel system specifically designed to suit the ergonomics of the modern neurosurgeon.
What I found most interesting about the Saraj Retractor is how it addresses the visual field. The paper highlights that this system is designed to work without disturbing microscopic and endoscopic vision. When we are working in a narrow corridor, say down a transcortical route to the lateral ventricle, the last thing you want is a bulky retractor blade or a fixation arm creating a shadow or blocking your instrument maneuverability.
Right, and the bidirectional aspect mentioned in the paper is key. In deep-seated surgeries, you aren't just pushing the brain in one direction. You often need to create a stable, symmetrical corridor. The Saraj system is built to facilitate this bidirectional retraction of normal overlying brain tissue. This is crucial for lesions like posterior fossa tumors, where the working room is naturally constrained by the bony anatomy and the sensitivity of the brainstem and cranial nerves.
The study includes a comparative analysis with conventional systems. While we've relied on those older systems for years, the Saraj system aims to improve the interface between the tool and the surgeon's ergonomics. For the residents and students listening, ergonomics here isn't just about comfort. It's about the precision of the retracting force and the stability of the surgical field over several hours.
It's about the footprint of the retractor. If the Saraj Retractor can provide the same or better access to an intracranial hematoma or a deep tumor while taking up less space in the operative corridor, it's a win for the patient. The authors emphasize that this is particularly relevant for those deep-seated lesions, where every millimeter of visibility counts.
It also seems like they are targeting the integration of different modalities. Because it doesn't disturb the endoscopic vision, it allows for a best-of-both-worlds approach, using the microscope for the main dissection and perhaps the endoscope for inspecting the corners of the resection cavity without having to reposition a cumbersome retractor system.
That's a great point. Innovation in neurosurgical instrumentation often lags behind our imaging and navigation capabilities. Seeing a dedicated effort to rethink the retractor, something we use in almost every major case, is vital. The Saraj Retractor represents a move toward more specialized tools that respect the delicate nature of the brain tissue while acknowledging the surgeon's need for a clear, unobstructed path.
For our listeners, it's worth keeping an eye on how these novel systems perform in long-term clinical outcomes compared to the standard Elara or Greenberg-style retractors we all grew up using. The paper makes a strong case that it's time to move past the decades-old designs.
Agreed. If we can achieve better surgical access with less retraction injury, we are moving the needle in the right direction. Elara, any final thoughts on the Saraj system from the paper?
Just that it's a reminder that even the most basic tools in our kit are ripe for innovation. In the context of microneurosurgery, the retractor is the frame for our entire procedure. Improving that frame improves everything within it.
Well said. That's all the time we have for today's episode of the Neurosurgery Hub Podcast. Thank you for joining us for this deep dive into the Saraj Retractor.
We'll see you in the next episode. Stay curious and keep learning.